venous thrombosis. DVTs are quite common in hospitalized patients simply because the patient either has one or more of the varicose triad, which we'll discuss shortly. Even though the patient may come in fully mobile, upon admission, there will be some degree of immobility that will result, either imposed by their condition, let's say they're in pain, or they are medically restricted from moving because of a heart condition, for instance, wherein they have severe activity intolerance, or if doing so, like increasing activity, would put undue strain and harm to the patient. Table 37-7 compares superficial from deep, regardless of if it is superficial versus a deep vein. It doesn't make one less severe or less dangerous than the other, simply because a superficial vein thrombosis can progress to a deeper vein. The difference, of course, is the signs and symptoms. So here, look at the location. Obviously, that's a superficial vessel, so you can see it with your naked eye. I'm not saying you can see the clot, but you can see the inflammation of the vein, because it usually is reflected on the skin surface. As described here, you can see the redness, and it's observable along the stretch of the vein, along the course. So you can see where the redness is occurring right along the course of the vein. You can literally see it. So you'll see the localized redness, warmth, and induration. The swelling of the vein is palpable, so you can see the induration, the area where it is raised. Not so in deep veins. The only thing you'll see in deep veins is the swelling of the leg, and of course the pain and tenderness that the patient will be reporting. There is rarely any edema, on the leg, on the affected leg, if it's a superficial venous thrombosis. And as I already mentioned, if untreated, a superficial blood clot may progress to become a deeper one. As long as the DVT stays as a DVT, there's no problem. However, there's always a chance that that stationary thrombus can become an embolus. And you know the end result already. Patient will have a PE, and depending on the category, whether it's low risk or submassive, there's a chance for recovery. However, a massive PE can lead to obstructive shock, so that is definitely life-threatening. So something so small will cause death in your patient. Okay, there are 3 conditions known as the varicose triad that lead to formation of a clot. Before that, let us look at how a clot is formed. Let's watch a short video. Clotting cascade. So as we watch this video, there will be parts of the clotting cascade wherein it will help you understand how certain anticoagulants work. Okay, I'll pause the video when we get there.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated.
So this part here illustrates a broken blood vessel. So let's say this is a capillary or an artery or a vein. So the endothelium, which is the innermost lining of the vessel, is obviously broken.
This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor.
Okay, so again, the example here could be, this could be a paper cut, okay, or somebody checking somebody's finger for either to check the blood sugar or to get a typing and screening, for instance. So as the vessel is injured, they will release tissue factor and then watch what happens next,
which forms a complex with factor 7, finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet.
Okay, so that short section was the extrinsic pathway. So recall the time that you had a paper cut, or you got a needle prick from, or let's say you got a splinter, okay, from working outside. So you notice that after your blood comes out, the bleeding stops after a few seconds. So that was the extrinsic pathway. So you saw what happened after the vessel was broken, vessel or vessels were broken. The platelets start to be attracted because as soon as tissue factor is released, it will attract platelets to stick to the broken endothelium. So the cascade starts. So you have one platelet sticking, another platelet, and another, and another, and another. So bleeding stops after a few seconds. However, since they are obviously just a temporary plug, it's not stable because these are just a bunch of platelets sticking together. There is nothing holding them together. So again, that is the extrinsic pathway part. And then the intrinsic pathway takes several minutes to accomplish. And let's continue watching.
The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with 5A activate thrombin and
okay, so this is the part where your heparin works. So thrombin is an indirect thrombin inhibitor. So this is the part where heparin works. So therefore, if it prevents thrombin from being formed, there will be no clot. So it will stop, the cascade will stop right here. So it means that based on the action, heparin is a thrombin inhibitor, so therefore it will only stop future formation of blood clots. If you have an existing blood clot though, of course this was before you were given heparin, so you're admitted to hospital, you have a blood clot, we diagnosed the DVT, and then we started you on heparin. So the heparin will stop this section of the clotting cascade, meaning it will stop again only future formation of blood clots, as well as you already know the nature of platelets. Once a clot is formed, platelets are attracted to that clot, so therefore the clot will get bigger. However, once heparin is started, it will not do that anymore, meaning whatever size the existing blood clot is, it will remain the same because now you have heparin administered already, so it will now stop further increase of the size of the clot, and also it will also stop further formations of new clots.
It induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot.
Okay, so this is the end of the clot formation stage. Once a clot is formed, the next thing the body will do is start dissolving the clot, meaning with or without administration of thrombolytic agents, meaning drugs that will dissolve the clot, the body naturally dissolves the clot. In most cases of clotting, let's say you have a DVT or a submassive PE, for instance, not a really serious life-threatening pulmonary embolus, there will be no thrombolytic administration. It's really dangerous to give thrombolytics, so we try not to give it unless it's absolutely necessary. The body naturally dissolves clots as soon as they are formed. That's why you've already read about D-dimer. D-dimer is called a fibrin degradation product. So you saw the formation of a fibrin clot. After the clot is broken apart by the body, what's left of it are fibrin degradation products, which is now the D-dimer, making D-dimer a very good indicator of clotting in the body, meaning the higher your D-dimer levels, the more clots your body is dissolving, and so that also means your body formed many clots. So it is used as a adjunct to diagnosis, but it can't be used to alone to diagnose the presence of a DVT or a PE, but it does help. Okay, it assists with the diagnosis of a PE. So let's continue. So that's how a blood clot forms. Now, what are the conditions that lead to that? We already know, based on the video, that it forms after endothelial damage, meaning you have an injury. So injury could be from trauma. It could be from surgery. Okay. One other well, it doesn't fall under endothelial damage anyway. So in certain cancer cells, which will fall under blood hypercoagulability, certain types of cancer release tissue factor for no reason, meaning for no in the absence of endothelial injury. Normally, tissue factor is released only by injured blood vessels. Thereby, you need to form a clot. In certain types of cancer, the cancer cells release tissue factor in the absence of endothelial injury. The other two risk factors that form the triad are venous stasis. So this would be any condition that leads to blood pooling. Most common cause is immobility. Now, immobility can come in different forms. We have a list actually that's coming up in the next page. So we have people who are immobilized for a long period of time, such as weak patients, unconscious patients, intubated patients. We have spinal cord injury patients. We have those who are paraplegics or quadriplegics. We have post-op patients who have decreased mobility, or let's say in severely ill patients like class 4 heart disease, for instance. Okay. And then we have hypercoagulable states. Let's look at the next table. Okay, so these are the conditions that reflect the Verco's triad. So table 37-8, look at venous stasis. So these conditions here, all of these guys listed here, have increased risk for venous stasis. One example is like this, for instance. We have if you have to sit for a long period of time on a 16-hour flight somewhere. We have obesity, which decreases blood return because there's so much pressure, or the increase in adipose tissue will make venous return extremely hard. Those who have orthopedic surgery, especially a hip or lower extremity, for obvious reasons, so it's very hard to move if you have those types of surgeries. Pregnancy, you have swelling already in your legs, so that's the evidence that there is low venous return because of the pressure of the growing uterus on your pelvis, thereby will impede venous return. And the rest you can already understand. Look at AFib, because AFib will result in blood pooling in the atria, and anytime again there is blood pooling on any of these conditions, platelets tend to stick together when they encounter each other for a long period of time. Endothelial damage from any of these conditions, again, this would be injury to the vessel that will automatically release tissue factor and trigger the clotting cascade. And here are the hypercoagulability states. So any condition that will thicken the concentration of your plasma, your blood, such as dehydration, for instance, or if you're taking OCPs, because that will increase the viscosity of your blood, it will cause water retention, increasing blood volume, increasing the thickness of your blood. Polycythemia vera is a chapter 30 disease under anemias, although this one is not the decrease of red blood cells but rather the increase. So in polycythemia, you have an increased number of your red blood cells, immature red blood cells, and they don't have the normal 120-day life cycle. So the sheer number of cells here, which by the way isn't just your red blood cells, polycythemia also increases the number of platelets and white blood cells at the same time. So all that traffic there, the blood becomes very crowded, too many cells, increasing the likelihood of blood clots. You learn later when you study or cover sepsis that sepsis will trigger a sequelae of other life-threatening conditions, because it leads to a severe inflammatory response syndrome, which will now trigger DIC, which is now DIC starts as a clotting episode, but then ends up with bleeding, because you form so much clots that you use up all your platelets to form clots, all your clotting factors to form clots, and then in the end you have nothing to form clots with, so therefore it will be followed by bleeding. Severe anemias, because you will also get hypovolemic in the end, so it will be the same effect as with dehydration. We already explained these. I'll go past that. Let's go now to the manifestations. There will be some differences, as already stated. We looked at the table comparing superficial from venous thrombosis earlier, so I'll review that again. In DVTs, there is usually unilateral leg swelling, meaning rarely does it involve both legs. Okay, most life-threatening complication, of course, is the PE formation. Diagnosis, I already mentioned that the D-dimer will help suggest the presence of a DVT, but in order to make a definitive diagnosis, it has to be confirmed with venous ultrasound. So this one is less expensive though, so therefore if the test comes back that your D-dimers are low or within normal, which is usually less than 250, then it's less likely that you have a blood clot, so they may not proceed with a Doppler ultrasound. But if it is, then that's highly suggestive of, the higher the number of your D-dimer, that's highly suggestive of blood clot formation, because your body is also dissolving a lot of those clots, so they will proceed with a duplex ultrasound. Because of the high mortality of a PE resulting from a DVT, we have an extensive and aggressive Vte prophylaxis. Every patient admitted to the hospital, regardless of age, is screened for the risk for the development of DVT. And as you can see already, based on the varicose triad, it could be any patient, because each of these risk factors listed here is 1 point. So let's say you have a 70-year-old patient who has a history of smoking, so that's 1 point for age, another point for smoking. That's easily 2 points there, and you only need 2 points in order to be at risk. So that puts pretty much everybody, almost everybody, at risk for a VTE. So what do we do once we have identified the risk? Okay, so we institute our preventive measures now. The most effective is early ambulation. However, if they can't walk, then we encourage them to do leg exercises while in bed, flexing the knees, performing leg exercises, turning them if they're unable to do, or if they can't do it themselves, we'll do passive range of motion. More effective ways will be taking them out of the bed. That way, because the only way blood returns to the heart is through muscle contraction. So unless those leg muscles are squeezed or the muscles contract, then venous return will be very low. So we do stockings, we do these compression devices, we call them SCDs or PCDs, whatever the hospital calls them. All of these promote muscle contraction, pressure compression on the legs. That way they will promote venous return. They keep blood flowing instead of pooling in the extremities. For even higher levels of prevention, we add anticoagulation now. You've seen it in hospitals. They typically use low molecular weight heparins, either 30 milligrams or 40 milligrams, or unfractionated heparin, 5,000 units, either daily, or if the risk is higher, they do it twice a day, or even 3 times a day. We have 3 major classes of anticoagulants, and this is used to both prevent and treat an existing DVT. Of course, when it's used for treatment, the doses will be higher. So let's discuss the 3 groups. One is vitamin K antagonist. This is warfarin. So if you review the video I showed you earlier, it did not mention vitamin K at all. The reason is vitamin K is not really involved in the clotting cascade, but rather vitamin K is necessary in order to produce 4 types of clotting factors. There are 4 vitamin K dependent clotting factors. I'm not sure which ones, whether it's factors 7, 8, and 9. I'm not really sure. But the point of vitamin K antagonist is it will prevent the synthesis of vitamin K. Therefore, if no vitamin K, then no clotting factor will be produced. So just as we said earlier that heparin will only prevent future formation of blood clots, or that they will prevent the existing blood clot from growing, vitamin K antagonists such as warfarin will only affect future production of clotting factors. It does not have any effect on the existing clotting factors already circulating in the plasma. So that would explain why there is an overlap in the treatment. So when we go to how the anticoagulants are administered, this will explain why the patient will be at one time getting heparin, both heparin and warfarin, because warfarin will take at least 3 days to begin having any influence on the clotting factors. So typically the patient may be on both heparin and warfarin for about 3 to 5 days before you see any movement or changes in the INR. So we monitor INR in warfarin and PTT in heparin. So there are 2 types of heparin. Unfractionated is the one with the shorter half-life, but they provide immediate anticoagulation, meaning as soon as you administer it, either subcutaneously or intravenously, the anticoagulation begins. So it will prevent immediately the formation of thrombin. Okay. This is your antidote, because bleeding is always a problem with any anticoagulant, and of course, since vitamin K is the one being prevented by warfarin, so therefore the antidote is also vitamin K. However, if the patient, let's say, consumed too much warfarin, vitamin K will not be enough as an antidote. In severe cases, the patient will have to receive fresh frozen plasma, because this plasma contains clotting factors, so that would be a more effective reversal of warfarin. So let's say in the event that the patient ended up with too much warfarin, too much vitamin K antagonist, vitamin K most probably will not stop the bleeding, so they will receive plasma instead. Low molecular weight heparin is an option if the blood clot is stable, meaning they just don't want any more new clots to form, or that existing clot to grow bigger. The doctor may decide, instead of putting them on long-term anticoagulation, they'll just be on it for a short period of time, for a few months for instance. So they will discharge them on low molecular weight heparin. LMWH have a longer half-life, making them safe to be administered at home. They have a 12-hour half-life. So these are also based on weight. The doctor will prescribe the dose based on the patient's weight. Because of that dosing, the dose therefore does not change. Once the doctor has prescribed the dose, that's it for the entire duration. Knowing that if the patient is on outpatient, therefore it doesn't make sense to monitor PTT anymore because the dose will not change. So regardless of the PTT reading, the patient gets the same dose, so making PTT monitoring totally unnecessary. But again, the doctor will decide which one will be used based on the size of the blood clot and also the patient's risk factors. Good thing we don't have to make that decision. With any heparin though, whether unfractionated or fractionated, a low molecular weight heparin, these are high risk for the development of HIT, which is heparin-induced thrombocytopenia. This is a genetic disorder. The patient develops an antibody against heparin, which can be life-threatening because the problem is, instead of the heparin preventing the formation of blood clots, once you develop HIT, you develop blood clots because the patient's body interacts and forms a complex with heparin, forming a blood clot. We'll discuss that under chapter 30. Low molecular weight heparins come in different administration syringes. They're usually pre-filled, unlike unfractionated heparin wherein you have to prepare it yourself. These pre-filled syringes come in different shapes depending on the brand. Enoxaparin in particular, here there's a warning here. If you're giving enoxaparin, there is an air bubble inside that pre-filled syringe. Says clearly here, do not try to expel that air bubble. The manufacturing company, the pharmaceutical company, put that air bubble in there. It's not designed to enter the patient, so of course you always hold a needle upright with the needle pointing down, so the air bubble rises and therefore doesn't enter the patient. It will just be stuck inside the needle shaft. This will ensure that the patient gets every drop of the medication. And the recommendation is always in the left or right antero-posterior lateral side of the abdomen. So that means your love handles, either the anterior love handle or the posterior love handles. That is the recommendation by the written on the drug book. The reason is those areas don't have muscle. Even if you're as jacked as I am, like my abdomen's really ripped, I do not have any muscles in the love handle area. There's just fat in there. Although, good luck finding fat on me. Thrombin inhibitors. Bivalirudin is only used for cardiac catheterization. It is a thrombin inhibitor, like argatroban, but I've never seen bivalirudin used for anything else. They only use it in cardiac catheterization to prevent clotting on the access site. Argatroban is the alternate. So let's say you have a patient with a DVT or a PE, but then they develop HIT, they develop heparin-induced thrombocytopenia, so therefore you can't use it anymore. Argatroban will be used instead. We have novel oral anticoagulants now. These are oral pills like rivaroxaban, apixaban, edoxaban. These do not require coagulation testing, meaning no PTT, no INR necessary. There are also no Diet restrictions, unlike warfarin, wherein you're restricted from eating too much food containing vitamin K because you can't eat the antidote at the same time you're taking warfarin. So that's why you can't eat so much salad anymore. It's not like you can't, you just can't eat too much. In these pills, these new anticoagulants, they do not have such restrictions. Okay, so you can do whatever you want. There's no need for blood monitoring. Again, the doctor weighs the risks and benefits of taking these, of prescribing these. There are some of them have antidotes, but not all of them have antidotes, so that's the downside also. This part here where it also says do not expel the air bubble, this is also in the Arixtra, or this is Fondaparinux. Okay, so this is a 10A inhibitor. They also prepared the injection, the prefilled syringe, the same way. There's also an air bubble in there. So this is a drug chart, so you know already what to study in any drug. So look at always the side effects, because we're always after patient safety. You should know what to teach the patient, and especially your responsibilities as a nurse administering them. Here are your levels depending on which drug the patient is receiving. Please know these numbers. The therapeutic values only, okay, because we don't want them to have normal, okay, because these patients have a clotting problem, so we don't want it to be normal. We want them to be higher than normal, so only remember the therapeutic values. For other patients who obviously don't need anticoagulation, then we need to know the normal value. But obviously for DVT patients, PE patients, we need their bleeding times to be therapeutic, which is higher than normal, but not too high either. This is a given. Of course, the patient is already on anticoagulants, so they don't need any more drugs that will increase bleeding. So do not give aspirin, NSAIDs, or even Plavix with these patients, okay, for obvious reasons. Here is your warning for warfarin. And we will discuss HIT in chapter 30, but be aware that this is because you're administering heparin here, so you should be aware of the possibility of HIT. We do not screen patients. There is a test that will test for the presence of the HIT antibody in the patient, but that's not routinely this is not routinely done. For one thing, there's so many patients receiving heparin, and these tests are not cheap. So but heparin is cheap, so we routinely continue to use heparin, but our job therefore is just to monitor the patient's platelets, okay, because that's your number one sign. Hence, that's why they call it heparin-induced thrombocytopenia. There are two types, but again, we will discuss that extensively in chapter 30. So here's the explanation why here you can discharge the patients sooner if on low molecular weight heparin. It has a longer half-life. Alright, and these are your novel oral anticoagulants. There are factor 10A inhibitors. Watch for the warnings. One of them will say, especially these, they are not known, they're not effective if the because they're used for AFib also, but if the AFib is caused by a valve problem, they are not effective. You probably heard the commercials. Let's say oh, I take this, but then I have AFib not caused by a heart valve problem. Okay, so that's one of the contraindications. There are surgical options for a DVT. If the patient, especially if the patient has either a very high risk of a recurrence, or if they have a contraindication for anticoagulation, say the age is too high, too advanced age, highly likely for bleeding, say they have peptic ulcers, for instance, and had a previous bleeding episode or hemorrhagic stroke, for instance, then they'll do surgery. For recurrent DVTs, they will implant a vena cava filter, an IVC filter. So this is an example. This is a Greenfield, I think. Yeah, Greenfield filter. So it's an IVC filter, so inferior vena cava. So it will be implanted in the inferior vena cava. So you can see wires here, which is a mesh, and here are your blood clots. So the blood clots get stuck there, waiting for the body to be dissolved, to dissolve them naturally. It does have a failure rate because, of course, this is only put in the inferior vena cava. So what if the blood clot forms in the superior vena cava? So there's your failure rate there. Let's go now to how is it given. Okay. Oh, by the way, patients receiving anticoagulant therapy, here are your alerts, and here are your precautions as a nurse. So these are, you can say these are bleeding precautions, table 37-13. So this would answer questions on your tests about safety and managing anticoagulation. So if a patient is on anticoagulation, you must institute these bleeding precautions. Okay, you can read them on your own. And we have delegation questions here again. So who can do what? LPNs can give your anticoagulants again on stable patients. They can also even measure patients because the stockings, the antithrombotic stockings, are come in different sizes. Obviously, because if you put a large size on a skinny patient, then that's not compressing anymore. Or vice versa, if you put a small size on a really big patient, then that will cause constriction of blood flow, too much compression. And here are your nursing assistants. Okay, so they can do that. Okay, let's go. Where is the... Oh, here are more teaching. So obviously this is in the home once the patient is discharged and they're taking anticoagulants. These are your teachings for both the patient and the caregiver. In case the patient is bleeding and goes unconscious, then they need to know. Let me go back to how it's given. Okay. So the first drug that will be given is obviously heparin. On the same day, the patient will also be receiving warfarin. Okay, let me just go see. I think I passed it. Alright, let's begin here. So this is page 821. Alright, so the patient begins with heparin. So this will be IV, obviously, unless again the DVT is low risk or stable or too small. Otherwise, the patient is given heparin. If it's given subcutaneously, that is only for prophylactic purposes. For treatment, it has to be continuous IV infusion. And throughout the infusion, we have to monitor PTT to make sure we reach a therapeutic level and not too much either. I already mentioned that you should monitor the patient for HIT during the therapy. The fastest way you can do that is, the easiest way you can do that is, of course, to watch the patient's platelet count every day. If you notice a drop, especially a 50% drop from pre-heparin levels, then that's highly suspicious for HIT, and then notify the provider immediately. And protamine sulfate is your antidote. And I already mentioned, if the patient does develop HIT, argatroban, which is a direct thrombin inhibitor, will be used instead. Right? So the reason why we start warfarin on the same day is, of course, the patient will need to be discharged at some point, right? And we can't discharge them home with an IV pump with heparin infusing, and it's not going to be like that forever. So the patient has to be discharged on an oral anticoagulant, which usually is warfarin. For a DVT, our therapeutic INR is between 2 to 3. Again, because of how warfarin works, it will take a few days for the existing clotting factors to be consumed or eliminated from the body. Because remember, vitamin K antagonists such as warfarin will only affect future production of those 4 clotting factors. Therefore, you need to wait until the body naturally got rid of those clotting factors before you reach an INR of 2 to 3. And then once you reach that, then we can stop the heparin, and then we can safely discharge the patient, and then just manage the anticoagulant as an outpatient. So during the first part of the therapy, we'd like to monitor the patient's INR at least once a week, and then we can go monthly after that, but the frequency is decided on by the physician. I already mentioned that thrombolytics is rarely used. This is a very dangerous drug. It's very effective. Yeah, it will dissolve any clot. The problem is it is rather too effective. It can also cause bleeding because it will dissolve any clot found anywhere in the body. So let's say you have an elderly patient who may have a bleeding peptic ulcer, for instance, which has stopped bleeding because there was a blood clot there. So after you give the thrombolytic, it will dissolve that clot, so it may lead to hemorrhage. Another option is to directly inject, meaning instead of administering the thrombolytic intravenously, they can also administer this intra-arterially, in small amounts, in order to administer the blood clot wherever it is. So let's say in a stroke patient, for instance, who missed the 6-hour window, they will administer thrombolytics like that. So it's an option, but again, all these the physician decides that. Okay, and that is for DVTs.